Our, our patient.
Just a moment, Harini. Who's looking after this session? Is it Harini?
Sorry, sir.
Are you looking after the session, Harini?
Yes, I am.
Okay. Is the auto admit still on? Because I could see that there are 6, 7 vacancies that we
Yeah,
have.
yeah,
That's why I'm
it's
asking.
still very much on, sir.
Okay, fine, fine. Will do. Okay. Everyone, chalo, continue. Chaitvvi.
Yes, sir. The patient, a 38-year-old female resident of Parel, hailing from Satara, Hindu by religion, homemaker by profession, educated up to 12th standard and belonging to upper lower socioeconomic class according to modified Kuppuswamy classification, is a G4 P2 L2 A1 who is booked at K.E.M hospital with 12 ANC visits and is immunized. Her last menstrual period was on 11th December 2024 with expected date of delivery being 18 September 2025, and her period of gestation is 31 weeks plus 5 days, and her blood group is B positive. So our patient presented with chief complaints of pain in abdomen 7 days ago, followed by bleeding per vaginum 4 days ago. So the patient was apparently all right 7 days ago when she started feeling the pain in her abdomen. She described it as a feeling of tightening in her belly. Pain was associated with loss of fetal movements, site being in lower abdomen. It was insidious in onset, gradually increasing in frequency, duration, intensity, and the last episode of pain in abdomen was 4 days ago. Pain persisted for 15 to 30 minutes with 2 to 3 episodes per day, and it was not associated with lower back pain. 4 days ago, the pain was followed by an episode of pervaginal bleeding. It was one pad filled over a period of around 4 hours, after which the patient presented to our emergency and was stabilized. Patient doesn't recall the details of the treatment given to her, and she is now stable and perceives fetal movements well. There was no history of leaking per vaginum, no history of headache, palpitations, loss of vision, or difficulty in breathing. There was no history of fever or suprapubic pain or burning micturition. There was no history of trauma or fall. There was no history of diarrhea or constipation or eating of outside food. The patient is a known case of gestational diabetes mellitus, and she was diagnosed after deranged RBS followed by deranged OGTT. Patient was found to have excessive volume of liquor in the USG scan, which was done at 30 weeks of gestation. So our present pregnancy, it is a spontaneous conception diagnosed at 6 weeks of amenorrhea by urine pregnancy test, and it was confirmed by USG, and her dating scan was done at 8 weeks. Folic acid and calcium supplementation was started in the first trimester, and there were no history of excessive early morning nausea or vomiting, no fever with rashes, no history of bleeding per vagina, no history of radiation exposure, and no history of any other drug intake. She had a total weight gain of 3 kgs in the first trimester with 4 ANC visits, and the rest of the first trimester was uneventful. In the second trimester, she had 4 antenatal visits and she felt quickening at 5th month. Fetal anomaly scan was done at 20 weeks, sorry for the typo, and it was normal. Vaccination status, TD vaccine was taken at 22 and 26 weeks, and it was 2 doses. Iron and folic acid and calcium supplementation was started, and patient noticed hard stools, which was suggestive that she was compliant to medications. History was of excessive weight gain, which was around 7 kgs. There was no history of bleeding or leaking per vaginum or abdominal pain. There was no history of decreased urine output or headache or blurring of vision or epigastric pain, pedal edema or breathlessness. Patient was diagnosed with GDM in view of deranged random blood sugar, which was done during a routine ANC visit, after which she was subjected to an OGTT test at 24 weeks, and that came out to be deranged. She regularly does self-monitoring of her blood glucose levels, and she is currently on metformin, and her blood sugar is well controlled. In the third trimester, she has had 4 antenatal visits till now. Fetal movements were perceived normally 12 to 15 times a day. Growth scan was done at 30 weeks, and there was a suspected large baby. In the same USG scan, it showed polyhydramnios. Iron, folic acid, and calcium supplementation are continued, and she still is compliant to them. There is no history suggestive of any premonitory signs of preeclampsia. There are no complaints of breathlessness. She noticed edema over her feet, which disappears with rest. There is no bowel or bladder disturbances. There is no history of leaking per vagina. No history of discharge or burning micturition or fever. And she had the episode of abdominal pain followed by bleeding per vagina, as we stated previously. Menstrual history. So she achieved menarche at the age of 14 years and has regular menstrual cycles with bleeding for 4 to 5 days at regular 28 to 30-day intervals with moderate flow and not associated with pain or passage of clots. And her last menstrual period was on 11th of December 2024. Marital history. She has been in a non-consanguineous marriage with active married life of 14 years. And there is no history of contraceptive, although the patient is aware about the use and the types of contraceptives. And in her past obstetric history, she has had first child as female, which is currently 14 years old, full-term normal vaginal delivery, cried immediately after birth and birth weight being 2.7 kg. There was no NICU stay and delivered at K.E.M and was breastfed 2 hours after birth, and there was spontaneous labor. There were no blood transfusions or no other complications during labor, and she is alive and well. After which she had an abortion 12 years ago at 12 weeks of gestation. Gender was not known and cause was unknown. It was spontaneous abortion and check curettage was done. There was no foul smelling discharge or fever post abortion, and regular menses resumed after 2 months of abortion, and she was not prescribed any contraceptives after that. After which she had a female child, 9 years old, full term normal delivery, and she cried immediately after birth. Birth weight was 3.1 kilogram. There was no NICU stay. Delivered at K.E.M and breastfed 3 hours after birth. Again, spontaneous delivery, no blood transfusion or no other complications, and she is alive and well. And patient has no history of diabetes during any previous pregnancies and no congenital anomalies in the living children. Past medical history. She is currently on metformin 1 tablet daily, along with iron, folic acid, and calcium supplements. No previous history of diabetes, TB, TB contact, hypertension, seizure, jaundice, asthma, or allergies. No history of any chronic medical illness or long term consumption of any drug. There was no surgical procedures except check curettage done. And there is no history of blood transfusion or transmission of any sexually transmitted diseases. Family history is negative for diabetes, hypertension, TB, congenital anomalies, genetic disorders, or preterm labor in the family. Personal history, sleep, appetite, bowel, bladder function is normal. Patient denies any history of addictions or any drug allergy. Diet history, she consumes mixed diet. Currently, she has been prescribed hospital diet for diabetes and she follows a sedentary lifestyle. Based on her 24-hour recall diet method, her calorie intake was 1805 compared to the 2100 which is required. So there is a deficit of 295 calories, and protein intake is 52 grams compared to requirement of 70 grams, and there is a deficit of 18 grams of protein. So summary after the history: 38-year-old G4P2L2A1 at 31 weeks plus 5 days of gestation, LMP 11th December 24, EDD 18 September 25, presented with chief complaints of intermittent abdominal pain for 3 days, 7 days ago, along with one episode of pervaginal bleeding. She said that the pain is progressively increasing in intensity and frequency and is associated with loss of fetal movements. There is no history of leaking vaginally, infections or symptoms suggestive of preeclampsia, no complaints of breathlessness. She is a known case of gestational diabetes mellitus, currently on metformin. She was also diagnosed with polyhydramnios on USG. Her past obstetric history was not significant. She is currently stabilized in hospital and admitted for further evaluation and treatment.
Patient was examined in a well-lighted room after obtaining due consent. She was alert, cooperative, well-oriented to time, place, and person. On general examination, the patient is comfortable at rest, with medium build and averagely nourished. Her pre-pregnancy weight is 51 kg and current is 63 kg. Her height is 162 centimeter. Her pre-pregnancy basal metabolic index is 19.43. Her gait is normal. Pallor is present. Grade 1 pedal edema till ankles is seen. No, there is no icterus, clubbing, cyanosis, and lymphadenopathy. There is no visible thyroid swelling. There are no features of PCOS, that is acne, hirsutism, or acanthosis nigricans seen. There are no varicosities over the leg. She is afebrile. Her pulse rate is 82 beats per minute, regular, good volume, and normal character. Her peripheral pulses were palpable. Her respiratory rate is 18 per minute. It was abdominothoracic and no audible grunt or wheezes heard. Her blood pressure is 122 by 84 millimeter of mercury, measured in right upper limb in sitting position. On thyroid examination, it was normal. There is no swelling in neck region. On breast examination, breasts were tender, showing normal changes of the pregnancy. There is no retracted nipples or fissures or cracks or discharge or palpable mass. On obstetric examination, on inspection, the abdomen is overly distended, umbilicus is inverted, linea nigra and stria gravidarum are present. No scar, sinuses, or dilated veins seen. Hernial sites are free of cuff impulses. On palpation, fundal height corresponds to 36 weeks of gestation. Symphysiofundal height corresponds to 37 centimeter. Her abdominal circumference is 92 centimeter. The uterus was relaxed. There was no tenderness. On Leopold grips, the fetal parts were felt with difficulty. In the first Leopold grip or the fundal grip, it was empty. No fetal parts were felt. On the lateral grip, on the left side, hard globular ballotable mass suggestive of head. On the right side, broad, soft or irregular non-ballotable mass is felt, which is suggestive of breech. The first pelvic grip is empty. On the second pelvic grip, it confirms the finding of the first pelvic grip, which was also empty. And on auscultation, the fetal heart sounds were not heard clearly. On systemic examination, on cardiovascular in the cardiovascular system, S1 and S2 were heard normally. No murmurs heard. On respiratory system, air entry bilaterally equal. No adventitious sounds heard. In central nervous system, the higher mental functions were normal. Sensory and motor system was also normal. Case summary: 38-year-old, gravida 4, para 2, living 2, and abortion 1 at 31 weeks plus 5 days of period of gestation. Her last menstrual period is on 11th of December 2024 and expected date of delivery being 18 September 2025. Presented with the complaints of intermittent abdominal pain for 3 days. 7 days ago, along with one episode of per vaginal bleed. She said that the pain is progressively increasing in intensity and frequency and is associated with loss of fetal movements. There is no history of leaking per vaginum, infections, or symptoms suggestive of preeclampsia. There were no complaints of breathlessness. She is a known case of GDM, currently on metformin. She was also diagnosed with polyhydramnios on USG. Her past obstetric history was not significant. She is currently stabilized in hospital and admitted for further evaluation and treatment. On general examination, findings are within normal limits. Her pulse rate is 82 beats per minute and BP being 122 by 84 millimeters of mercury. Obstetric examination revealed an overly distended uterus with fundal height more than period of gestation and a single live fetus in oblique lie. Fetal parts were felt with difficulty. Fetal heart rate was not heard clearly over the abdomen. She is currently stable with no uterine contraction and there is no uterine tenderness. So the provisional diagnosis of our case is a 38-year-old female, gravida 4, para 2, living 2 and abortion 1, with last menstrual period on 11th of December 2024 and expected date of delivery is 18 September 2025 at 31 weeks and 3 days of gestation, presenting with chief complaints of pain in abdomen associated with loss of fetal movements, along with one episode of per vaginal bleeding, and is a known case of gestational diabetes mellitus, currently on medications with polyhydramnios, diagnosed on ultrasound with no history suggestive of signs of preeclampsia, is likely a case of threatened preterm labor with a single live fetus in oblique lie, not currently in labor, as suggested from the history and clinical examination.
Uh, Good case, Chaitvvi and Darshana. Could you just go back to your first slide?
Yes, sir.
Okay. By the way, keep this slide, but I just want to ask you a question given the diagnosis that you have given me. When you
Yeah.
have a female who is coming to you who has signs of polyhydramnios, is a known case of diabetes mellitus, and is giving you history of loss of fetal movements, what is going to be your first differential? First.
Sir, if I would first think that she is not able to feel the fetal movement because of polyhydramnios, and if on examination I cannot suspect, then I would suggest it is a sudden IUFD in view of the gestational diabetes.
Yeah, very good. Although the non-perceiving of the fetal parts is the commonest and the most common reason, in fact, but the most dreaded diagnosis would be sudden IUFD more so because she's diabetic. Anyway, I'll come to that later. In your case, in your demographic details, is there anything that is significant that makes you think that polyhydramnios or preterm labor might be because of that? Anything in your demographics?
Sir, lower socioeconomics class, it is more common to have preterm labor.
Darshana, your voice is not clear. Could you just move a little more towards the mic?
Sir, in the lower socioeconomic class, it is mostly sent to have preterm labor as a common condition because they have low nutritional status.
Okay, I would agree with that. Could you tell me why should lower nutrition status be a reason for preterm labor?
Sir, the uterus.
Inadequate nutrient supply will cause impaired fetal growth, so there will
Your
be
voice is
anemia.
extremely poor. Could you be a little more lucid and louder, please?
So, sir, because of poor nutrition, it can cause IUGR and
Okay,
fetal stress, which can trigger preterm labor.
There are chances of having infections during the period of pregnancy.
okay. The voice is still not clear. Please do something about the voice. I'm just about able to hear a few words, and I don't think that's a great thing right now. Could you just repeat your answer again?
So, sir, we have like because of increased micronutrient deficiency, there will be increased case of IUGR, which will cause fetal stress and which will cause preterm labor to deliver the fetus before the conditions worsen. Also, there will be increased susceptibility to infections of genitourinary tract or periodontal diseases and increased cytokines.
Very good. Your voice is still not clear, but I will just repeat your point. Please do something about the voice. If required, just come through other device, but just sort that out. But until then, that's a great reason that you have mentioned. That's very correct. So the reason that a female who is from a lower socioeconomic class and is poorly nourished, as also your BMI is suggesting that she only has a BMI of somewhere around 19. In that case, first of all, because of her poor nutrition, she is going to have deficiency of micro as well as macronutrients, I would say. And that in itself is a reason why her immunity is going to be low on the lower side. And that gives rise to an increased chance of vaginal tract infections, genital tract infections. And whenever there is any infection, there are going to be several cytokines that are released. And one of the cytokines happens to be prostaglandins. In fact, in any infection, prostaglandins are the reason why you also get fever because it changes the thermostat in your hypothalamus. But the biggest problem that is going to occur is that when these prostaglandins are released inside my vaginal tract, genital tract, they are going to lead to cervical ripening and also uterine contractions. So that is the problem that you have to keep a note of, that poor nutrition is going to lead to infections, and those infections are going to release prostaglandins. Prostaglandins are going to be released by any infection in the body, but unfortunately in the vaginal tract, they will initiate preterm labor. And also they can lead to premature preterm rupture of membranes. So that is a big risk factor. Okay. Apart from that, lower socioeconomic class, will age have anything to do with your case?
Sir, so she is more than 35 years of age, and preterm labor is more commonly seen in maternal age less than 18 or more than 35 years of age.
Very good. And anything about polyhydramnios? And by the way, your voice is very clear now. Thank you. So anything about polyhydramnios and the age?
Sir, so she
Think about an increasing age and which medical disorder is going to get much more common.
So, gestational diabetes mellitus is more common in elderly females, so it can cause
Very,
polyhydramnios in the
very good.
pregnancy.
Not just gestational, but even overt diabetes mellitus, anything that is metabolic syndrome, hypertension, overt diabetes, all of these are going to be much more common in elderly women. And hence, that might be one of the risk factors, although Your patient, it may or may not be the case, but it is one of the risk factors that will lead to diabetes in pregnancy and eventually polyhydramnios. Okay. Apart from that, she's 31 weeks of gestation now. So if she's going to deliver today at 31 weeks, 5 days, what type of preterm birth would it be?
Late preterm. Good. Sir, it would be a late.
Early
It's
preterm birth, sir. Early
early
preterm birth.
preterm. Yeah, early preterm.
Before
Late
34
preterm
weeks.
is
Between
not.
34 to 37.
Yeah, very good. So could you just tell me what are the various types of preterm birth, the various nomenclatures?
So, sir, there is a late preterm, which
Early.
is 34 to 37 weeks.
Okay.
Early
Is there
preterm, which
anything like early, late preterm? Is there anything like that?
Sir, according to ACOG classification, we classify it as early preterm less than 34 weeks, and between 34 to 37 weeks, we consider it as late preterm. But
Okay.
we have another classification also, which has late preterm birth between 34 to 36 weeks plus 6 days, moderate preterm birth between 32 weeks to 34 weeks plus 6 days, very preterm birth less than 32 weeks, and extremely, we consider it for less than 28 weeks.
Excellent answer. Perfect answer. Nothing more required. Good. Okay, fine. So if she's going to deliver today, what is she going to be?
according
Moderate, according to WHO classification, it is very
Very
preterm birth.
preterm. Exactly. She's going to be very preterm. Fine. You have mentioned her blood group over here. Is there any correlation with the blood group you have specifically mentioned it?
Sir, so because she is B positive, so the chances of RH isoimmunization with RH negative pregnancy is less, and RH negative pregnancy is a predisposing factor for polyhydramnios because of hydrops.
Okay, very good. Could you just tell me as to why should hydrox fetalis lead to polyhydramnios? The answer is correct, but could you tell me why? Darshana?
So, sir, hydrops might be because like uh, fetal urination and there is lung fluid. So, in hydrops, the anatomical
Defect.
obstruction can cause fetal obstruction to swallow, and there
Very
is
good, very good, very good. So basically, there is an obstruction to fetal swallowing. Why is there an obstruction to fetal swallowing? First of all, because of hydrops, all the pleural membranes are full of fluid. Also, your pericardial membranes are full of fluid, and all these membranes, your pericardium and your pleural membranes, these are all around the trachea. So they are going to compress the trachea and they are going to impair swallowing. That is one of the first reasons. Secondly, in patients with hydrops, they're often, especially in hydrops because of isoimmunization, there is cardiac overload because of excessive fluid volume in the fetus. So whenever there is an increased fluid volume in the fetus, it is going to go more towards the kidneys and the GFR is going to increase, the fetal GFR, and that is increasing your urination. Apart from that, when the placenta starts realizing that my fetus is failing, more so because of isoimmunization, because it is not able to produce its own RBCs, they are getting destroyed. The placenta says, let me try to help you. So how does it try to help? It starts enlarging. So you get signs of placentomegaly. Placentomegaly, when your placenta size increases, your surface area of the placenta increases. Remember that in the first trimester, two mechanisms of production of amniotic fluid include transmembranous and intramembranous. Transmembranous is through the amniotic membrane and intermembranous is going to be through the blood vessels on the surface of the placenta. So when the surface area increases, so does the transudation from these membranes and hence your amniotic fluid increases because of this factor as well, placental factor. Now that I've mentioned this, could you tell me what are the ways in which amniotic fluid is produced?
Sir, in the first trimester, it is because of the ultrafiltration from the maternal plasma. In the second trimester, it is from the fetal skin, but at 22 to 25 weeks, the fetal skin has keratinization occurs in the fetal skin. So after 20 weeks, it is because of the fetal urine or and fetal lungs can also produce.
Okay, excellent. Very good answer. So, what are the various modes of amniotic fluid production in the first and second trimester, early second trimester? One is what you mentioned as ultrafiltration. Any other modes as well? Other is fetal skin. Anything else?
Mm, exchange of fluids across the chorionic
Placental
plate.
membranes,
Huh.
exactly. So transmembranous and intermembranous, that is through the fetal vessels and the amniotic cavity, and also amnion that is present on the placenta. So all these are the methods. This is how amniotic fluid is produced. But this amniotic fluid is continuously getting recycled by the fetus. How does that happen?
So first there is fetal swallowing, and then there
Okay,
is fetal urine production, and lung fluid secretion, and intramembranous flow.
okay, very good. So could you tell me why should polyhydramnios happen?
So polyhydramnios can be because of
Large size of the placenta, which can be due to twin pregnancy or Rh negative
Would you want
pregnancy.
to clarify your answer a little more?
Acha,
Under
Yes.
so there
fetal,
are
maternal, yeah.
so there are maternal causes, fetal causes, placental, and idiopathic.
Okay,
So maternal, there would be diabetes and Rh incompatibility,
Also,
okay, very
twin
good.
pregnancy.
Which
and
twin
then
pregnancy? BCDA? You have to be a little more specific.
uh, sir, could you repeat the twin pregnancy point?
You mentioned that twin pregnancy is a reason why there is going to be polyhydramnios. Are you sure it is a reason for polyhydramnios or is it a reason for excessive uterine or fundal height?
Sir, it is a cause for excessive uterine height, but in if there is MCMA twins or MCDA twins, then there can be twin transfusion syndrome, in which one of the twins can be subjected to polyhydramnios.
Okay, very good. There is one point that you aired over here which you shouldn't have said, and that is MCMA. Remember this. We are going to be discussing this in multiple pregnancy anyway. MCMA twin will never have twin transfusion syndrome. It's a classical disorder of MCDA. The reason is in MCMA, apart from that main connection, the arteriovenous connection that is there in your twin transfusion syndrome, there are several more, a lot more superficial, smaller connections which negate the pressure difference between both the fetuses, which is why twin transfusion syndrome doesn't develop. Whereas in MCDA, this doesn't happen. There is that one major connection that leads to twin transfusion. There is nothing to negate the pressure differences, and hence you have all its complications. So it is only MCDA which will give rise to polyhydramnios and oligohydramnios in each twin simultaneously. So do not forget it is only MCDA. You can just say monochorionic, but do not say MCMA and
Oh,
definitely not DCDA. Okay, so
okay, sir.
fetal causes, you mentioned one
Fetal,
is
so there is congenital malformations like anencephaly or
okay,
neural tube defects like spina bifida.
okay,
Then, if there is impairment of fetal swallowing, like esophageal atresia, duodenal atresia, or tracheoesophageal fistula,
very good.
then fetal hydrops, again swallowing impairment,
Yes, very good.
then fetal aneuploidy,
Okay,
multiple pregnancy done.
Parvovirus B19
Huh.
infection, it can be due to fetal anemia.
excellent answer, very good answer.
Uh,
So you mentioned a point about anencephaly. Could you tell me why does anencephaly lead to polyhydramnios?
for an anencephaly, there is increased transudation from the meninges of the skull. Also, there is the ADH is not produced in the fetus, so the fetal urine is increased,
Why is it
and
not produced?
Hypothalamus नहीं है ना anencephaly में.
absence of hypothalamus or skull is not present.
Excellent. The brain is completely absent, and so is the pituitary and the hypothalamus. You do not have the hypothalamus that will produce the posterior pituitary is not there, so you won't have ADH. Okay, what else?
And there is also swallowing defect. Swallowing reflex is absent because there's no brain, so there is
Mhm.
swallowing defect as well.
Very good, excellent. We'll just talk a little bit about anencephaly since we have opened the topic as well. Anencephaly, I have a fetus. Let us assume that it's a female who has not gotten herself registered. She has had her previous deliveries that were done at home, and she also had a short interconception period. But this time, when she came for her last visit to one of the peripheral centers, because she got to know, she started thinking that I have crossed my usual 40 weeks and I'm still not delivering. So she visited a hospital and it showed that she has anencephaly. So an anencephaly has unfortunately reached term. What are the complications that you expect that will happen with anencephaly at term? By the way, for everyone, anencephaly is going to be the commonest sample that you will find in your table viva in obstetrics. There is going to be one specimen of anencephaly that every single college will definitely have. So the next discussion is also going to help you out in that. So if an anencephaly reaches term, what do you expect?
So, sir, since there is anencephaly, so there is immature onset of labor because there won't be any hypothalamic pituitary adrenal axis to induce labor.
Very good. What is this also called as? There's a informal term for this.
I'm not sure, sir.
It is called as a fetal clock. Fetus ki ghadi clock. It is a fetal
Okay.
clock. Basically, the fetus realizes that it is time that I got delivered myself and it initiates its own labor. It's a discussion for some other day. It is basically the placenta and the fetal adrenal glands. They play with each other and they determine when should I initiate my labor. For those who are interested in knowing this, they can text me. I'll send you the link for this one. We have discussed this earlier. But the labor is going to be delayed because the pituitary is absent and hence your axis, your pituitary axis is cut off and the fetal clock is disturbed. So, first of all, it is going to go into postdatism. What's next?
So, sir, because of anencephaly, malpositions are very common, and also it is because it is associated with polyhydramnios. So,
Face presentation is most commonly seen because only face is formed.
Okay, but do you know that when the face is being presented, now this baby lacks a skull, the baby lacks a brain. So the diameter, the mentofrontal diameter is actually very less. It is 6 or 7 centimeters only. So technically, the baby should get delivered. What is the problem that will occur?
Sir, estrogen is not formed.
No.
sir, uh, maybe because of polyhydramnios associated with anencephaly, once the labor is induced, there can be increased risk of PPH or
No, not because of that. The answer is that whenever your baby has gone into postdatism, which your anencephaly will in most occasions, once it goes into postdatism, the baby's body is still growing, although the labor is not initiated, and the baby literally reaches macrosomic proportions. So, unfortunately, this baby is going to have shoulder dystocia. One of the commonest causes of shoulder dystocia is in a non-diabetic female or in a non-usually diabetic, over diabetic female is anencephaly. Because the baby's body is still growing and the brain is unable to signal to start its own labor. So the baby is going to be delivered at 41, 42, or even 43 weeks of gestation. The baby is going to be massive, 4.5 kgs, 5 kgs, and this baby is going to have shoulder dystocia. Face presentation, in fact, is not going to be a problem because the baby doesn't have a skull, the baby doesn't have a brain, so the diameter, the engaging diameter is going to be very small. The problem is going to be with the shoulders. So shoulder dystocia is a major problem in delivering babies with anencephaly. The good part is this baby is anyway lethal. It's a lethal anomaly. The baby will anyway die after delivery. So you can afford to have this shoulder dystocia. In fact, it's a good learning curve for a lot of obstetricians if they have to learn the maneuvers of shoulder dystocia because this baby is anyway not viable enough. Hence, shoulder dystocia is the answer that I was looking for. Okay. So coming back to the discussion, polyhydramnios, you mentioned maternal and fetal factors. There was one placental factor that you were mentioning. What was it?
Chorangioma of placenta.
Very good. What is chorangioma?
Sir, there is excessive growth in the single villus of the placenta.
Okay. I would rather want a little better answer. Chorangioma. Angio is vessel. Coro is chorion. So the chorionic vessels, oma is a tumor. It's a tumor of the chorionic vessels. So it forms a tuft. A tuft is like a ball of vessels on the chorion. And this, on these vessels, take up all the fetal blood. The fetal blood that comes into it leads to depletion of fetal blood volume that leads to eventually hydrops in the fetus because of heart failure. But it also leads to so much of fluid inside those vessels that it starts transudating out the fluid, and that leads to your polyhydramnios. So chorangioma is a tumor of chorionic vessels. Okay. You mentioned neural tube defects. Which type of neural tube defects?
Sir, spina bifida.
Okay. Is there a broader term for it, name for it?
Open neural tube defects.
Yeah, open neural tube defect. So it can be anything. It can be a meningocele, meningomyelocele, spina bifida, anything. It can be any single thing in which or even anencephaly for that matter, in which your meninges are lying open. Remember, you cannot just say neural tube defect because a closed neural tube defect is not going to have any leakage of CSF in the amniotic cavity, and hence that is not going to have polyhydramnios. It is only open neural tube defect that you should be mentioning will cause polyhydramnios. Okay. Now that we have anyway spoken about polyhydramnios, could you just again enlist me the causes of oligohydramnios?
So, sir, in oligo also there are maternal, fetal, placental, and idiopathic.
Okay.
For maternal, there will be preeclampsia or chronic hypertension because that affects the formation of vessels. So there is decreased exudation from the vessel.
Okay.
Then there is
Anything else?
uh, postterm pregnancy, sir. Postterm
Yeah,
pregnancy.
postpartum pregnancy. Okay.
Th- then there is placental insufficiency and drugs like ACE inhibitors.
Okay.
In the
Fine. Good. Why ACE inhibitors?
Sir, because ACE inhibitors will decrease urine output.
Of the mother?
Of the fetus.
Very simple. ACE inhibitors are contraindicated because they lead to even possibility of renal agenesis in the fetus. So if there is renal agenesis, if the kidneys are only not formed in the fetus, how is it going to even produce urine? So anything that is related to the renal tract of the fetus, which includes the drug ACE inhibitors or angiotensin receptor blockers, apart from that, also if there is any blockage, that is lower urinary tract obstruction, that will also lead to oligohydramnios in these fetuses. Okay. What are going to be your examination differences or examination findings, the differences in them between poly and oligohydramnios?
Also, sir, on examination, polyhydramnios will have abdomen distension greater than the period of gestation.
Okay.
Oligo will have less. And in
Okay.
polyhydramnios, fetal parts are felt with very difficulty, whereas in oligohydramnios, the baby is very easily felt. Like it is just baby as a
Full of
phenotype.
fetus.
Huh.
Okay. Okay. What else?
Also, in oligohydramnios, there is reduced maternal weight gain.
Hmm.
And
Okay.
whereas in polyhydramnios, there is increased weight gain with edema and pressure symptoms.
Okay. Fine. What
Also,
else?
there might be evidence of IUGR, and the mother might be having hypertension in cases of oligohydramnios.
Okay. Okay. Fine. Correct. ठीक है. Next slide. Okay. Nothing. Pain in abdomen 7 days ago. Why do you think she must have had pain in abdomen at this gestation?
So there can be multiple reasons. One of them being normal medical causes of abdominal pain, and secondly being Braxton Hicks contractions, which are seen in third trimester.
Okay. What more specific to this patient?
So, because of the increase in the size of the uterus due to polyhydramnios, there might be contractions might start in her.
Okay, so uterine stretch is going to lead to preterm labor and contractions, and apart from that, the mere stretching of the uterus and all the ligaments around it that are stretched because of the polyhydramnios. That is going to be the reason why this pain is occurring for us. So it may not only be preterm labor, though in your case it is, I guess, but even otherwise, the pain can be because of the uterine stretching and the ligaments like round ligament and the uterosacral ligaments that are getting pulled, which leads to this pain in a patient with polyhydramnios. And she also had bleeding per vaginum. How do you associate bleeding per vaginum with polyhydramnios or your case in general?
Okay. So, because of the polyhydramnios, it can cause abruption of the placenta.
Okay, why?
Overdistension due to the amniotic fluid will cause if there is sudden decrease in uterine membrane, uterine size because of a rupture of membrane, then there can be
Pressure
rapid
difference.
shrinking of the uterus, which will separate the placenta.
Very good. So basically, the loss of fluid because of PROM, that is preterm premature rupture of membranes or preterm premature rupture of membranes, will suddenly make the uterus contract, and sudden contraction is always discouraged in a pregnant uterus because that is going to lead to separation of the placenta, and hence abruptio placentae is very common, and hence that might also be the cause of her bleeding per vaginum. How will you differentiate whether the bleeding per vaginum is because of labor or it is because of abruptio placentae?
Uh, Sir, we do a test known as app test.
Which test?
App test or Singer's alkali denaturation test.
Oh, acha, wow, this is something new. Please tell me about it. I have to differentiate between bleeding per vaginum because of abruptio and because of onset of labor. How do I differentiate? You are telling me about the leaking membranes. The answer that you gave me is for amniotic fluid. It is not for blood. So the way I can differentiate is it is going to be the blood that you get at the onset of labor is because of the show, the release of show. What is show? Show is basically that mucosal plug that is present at the level of the cervix. It is a mucosal plug which also contains immunoglobulins, immunoglobulin A to be more specific, that prevents the entry of any organism inside the uterus. So whenever it is preventing the entry of anything, the moment labor begins, this plug is expelled. And when it is expelled, along with it, there is some blood that is shed. This blood that is expelled and the mucosal plug that is expelled is called as SHOW, SHOW. This is extremely thick and it really looks like mucosa that is stained with blood and it is not looking like pure blood. Whereas in a patient with abruptio, you're going to have blood depending on what type of abruption it is. If it is revealed abruption, it is going to look more fresh, more red, bright red. And if it is concealed abruption, it is going to be dark red in color, almost brownish in color, and it is going to be in the form of a clot. So that is how you will differentiate between whether it is true or abruptio related bleeding. In fact, the patient who is coming to you with polyhydramnios, bleeding per vaginum, and absent fetal movements can also be an IUFD because of abruptio placentae in your case. Okay.
Yes, sir.
Okay. Next point. The patient was apparently all right 70s ago and she pain. It was tightening, was associated with fetal movement, side being in the lower abdomen. Okay, you have mentioned, you have described the type of pain that she had. How do you differentiate between labor pain and a false labor pain, true and false labor pain?
So in true labor pain, there is a radiation of the pain from the lower back to the front of the thighs and the abdomen. While in false labor pain, it is a localized pain. Um,
Okay.
During true labor pain, there is also effacement of the cervix, while it is not seen in the false labor pains. And the true labor pains, goes on increasing in the intensity and frequency with time, while the false labor pains remain constant in the intensity.
Yeah, very good. Good answer. So it is erratic and irregular, that is Braxtonix or false labor pain, whereas your true labor pain is regular, it is continuous, and is increasing in intensity. And always your true labor pain is going to be associated with some cervical change. That cervical change may be dilatation, it may be effacement, can be either of them. Whereas your false labor pain is never going to be associated with that. So in your case, it is looking likely that it was a true labor pain that was initiated because she also had passage of blood. And also, you have mentioned that it is gradually increasing frequency, duration, and intensity, which is very likely and putting it more towards preterm labor. So your diagnosis effectively becomes threatened preterm labor. Okay, so you have a female with threatened preterm labor. How are you going to manage it?
So, sir, first we will look at the period of gestation and the complications that she is presenting with preterm labor.
Okay,
So, if the patient is more than 34 weeks of gestation and she is coming with preterm labor, we will, and if she is in a good institutional facility with labor care, we will allow the labor to progress and cause, for allow the labor to progress to delivery.
okay,
But but if the labor, if the period of gestation is less than 34 weeks or it is very early preterm, then we would like to, and if there is no indication of delivery like infection or chorioamnionitis, then we will allow, we will give her tocolytics, progesterone, and to give time for antibiotic cover and for administration of steroids for lung maturity.
okay. Would you give steroids after 34 weeks?
We can give, sir,
वो
if
इट इज either you will give or not. कैन तो मैं किसी को भी दे सकता हूँ, मैं तो पीएनसी पेशेंट को भी दे सकता हूँ, मेरे हाथ में इंजेक्शन आ गया मैंने दे दिया उसको, मेरा मूड था तो दे दिया. इट इज नॉट कैन. Should you give or not? What is the guideline? What is the recommendation?
sir, less than 34 weeks pe we give steroids for lung maturity. More than 34 weeks, it is not indicated.
So all the recent guidelines now say that if your patient is going in labor, vaginal trial of labor, then till 37 weeks of gestation, you should be giving definitely steroids. You should be giving. There is a definite benefit. A few guidelines also say that if your patient is not going to undergo vaginal trial and is going to be an elective LSCS because of something like previous LSCS or placenta previa or anything, and she's going to have an LSCS at 39 weeks of gestation, which is when we do elective LSCS, you should also still give them steroids till 39 weeks. Though this is not strictly followed, but there are guidelines that state this. The reason is that whenever your female is undergoing vaginal labor, at that time the baby's head is compressed, and this head compression is a stress on the fetus that releases endogenous corticosteroids. So all these endogenous corticosteroids are going to be released inside the baby if it is going undergoing vaginal labor. But if it is undergoing a cesarean section, an elective cesarean section, without going in labor at all, then this endogenous corticosteroid is not going to be released, and hence you would have to give her till 39 weeks. Although we do not practice this routinely, we still give all the patients nowadays steroids till 37 weeks of gestation because it has definitely shown to have a benefit even between 34 and 37. To be more specific, 36 weeks, 6 days, not technically 37, 36 weeks and 6 days. Okay. You mentioned about tocolysis. How long do you give tocolysis?
Sir, we can give it up to 48 hours.
Okay, 48 hours, very good. So 2 days. Why 48 hours? Is there any reason for that?
Sir, so effective peak efficiency of steroid administration is reached at 48 hours because the doses are, um, betamethasone is 12 hours apart, or sorry, betamethasone is 24 hours apart, or dexamethasone 4 doses 12 hours apart. So 48 hours में dose जाना चाहिए.
Very good. What is the dose of beta-methasone that you give?
Betamethasone is 12 milligram intramuscularly, 2 doses 24 hours apart.
Okay.
And Dexa would be 6 milligrams intramuscular, 4 doses,
12 hours.
12 hours apart.
Okay. Okay. What is what is your opinion on which is better, Dexa or Beta?
Beta is better than Dexa, but we give Dexa because it's cheaper.
Are you sure that we give Dexa, or do we prefer, or do we give Beta more commonly? Your answer was the other way around.
Sir, betamethasone is given worldwide, but it can also cause fetal hypoglycemia. While Dexa,
Hypoglycemia or hyperglycemia. It is a steroid.
Hyperglycemia होगा ना.
Exactly, उसने hypo बोला, hyper होगा. Any other reason not correlating with the glycemic part?
Sir, cost mainly.
नो, 3 रुपए का आता है डेक्सा, 8 5 6 रुपए का आता है बीटा का. एक इंजेक्शन का एम्प्यूल 3 रुपए का आता है. एंड अ टोटल कवर, आई मीन एक एम्प्यूल एक टाइम पे वी गिव 3 एम्प्यूल्स विच इज 9 रुपीज. 24 hours apart, 6 ampules, which is 18 rupees. 18 rupees is very cheap. So the reason is that, remember I had mentioned about the fetal clock. वो fetal
Yes, sir.
clock में there is a role for sulfate in the placenta. ये जो सल्फेट है, ये सल्फेट अपने को मिलता है डेक्सामेथासोन के केमिकल स्ट्रक्चर में. वी फाइंड sulfate in the chemical structure of dexamethasone, whereas we do not have any sulfate in betamethasone. That is the first reason why dexa is preferred over beta. Secondly, the salt, the salt as in the compound of betamethasone that is good and that should be given is acetate and phosphate wala mixture. But in India, we do not get a mixture. We only get acetate wala. And hence, the problem is that, sorry, अपने पास phosphate मिलता है, acetate नहीं मिलता है. And hence, ये जो phosphate वाला salt है जो अपने इधर मिलता है, उससे cerebral palsy होने के chances ज्यादा देखे गए हैं. Which is why DEXA is a preferred drug. It is only because our labor wards often keep, even in the college that you are in K.E.M hospital, it keeps dexamethasone. अपने ward में नहीं मिलता है, it only keeps betamethasone for whatever reasons there are. But dexamethasone is a superior drug to betamethasone. One small problem is that we have to give 4 injections of dexa, whereas only 2 injections of beta. So the compliance is slightly better with betamethasone. Dose miss नहीं होता है, and it is also a little more convenient for the female to just take one injection 24 hours apart, which is also why people are resorting to giving beta more. But no, dexa will always remain a slightly superior drug to betamethasone. Could you give the female, if you do not have dexa or betamethasone, could you give her hydrocortisone?
Sir, hydrocortisone has mineralocorticoid activity, so we would not prefer to give her hydrocortisone.
Very good. Prednisolone, उसमें तो दोनों का equal activity है. Can you give methyl prednisolone? The reason you cannot give any other steroid is that all steroids are metabolized by the placenta and they are catabolized. Whereas betamethasone and dexamethasone are not catabolized, they can directly go into the fetus and start their action, which is why only dex and beta cross the placenta, all other steroids do not cross. So, although your answer is right that glucocorticoid action is required, but remember that it is because the placenta catabolizes all the steroids and it doesn't catabolize. Hari Charles, whoever it is, kindly mute your microphone. But otherwise, you have to remember that other steroids are not going to be crossing your placenta. Got it?
Yes, sir.
Okay. Any other drug that you give for cover organizers? Could you please just mute Hari Charles?
Sir, we also give magnesium sulfate up to 32 weeks for neuroprotection.
Okay. What is the dose in which you give neuroprotection, Maxelf, and how long can you give it for?
so the loading dose is 4 gram, and for maintenance dose we give 1 gram.
Okay, the loading dose is 1 gram and the maintenance dose is 4 gram. Okay, so how long do you give it and until how many weeks of gestation do you give it?
So we can give it for around 5 to 7 days, after which it starts affecting the fetal bones, and we can give it up to a period of 32 weeks.
Okay, what did you say about 5 to 7 days?
Sir, 5 to 7 days. Till then, we can give magnesium sulfate. provided it does not cause toxicity. Because after
Absolutely
that,
not. 5 to 6 days will it will definitely cause toxicity, and this female will eventually just require hemodialysis to remove that magnesium from her blood. You only give it for maximum of 24 hours. So you have to begin the infusion so as to ensure that the delivery happens in the next 24 hours only. And you do not give it any longer than 24 hours for neuroprotection. ठीक है? Do you give a
yes,
repeat dose of magnesium sulfate अगर वो अगले 24 घंटे में डिलीवर नहीं हुआ 7 दिन के बाद होने फिर से लेबर में गई? Do you give a repeat dose?
no, sir.
Why? Magnesium sulfate is known to cause osteopenia. So osteopenia in the fetus, and hence you do not want to be causing that, and hence only one dose is given for magnesium sulfate. But that is not the case with steroids. Can you give a steroid as a repeat dose, and what is it called as? Kshitij, you had
So
asked this question. I'm coming to that.
we can give a repeat dose of steroids, but I mean the steroids have an effective period of 7 days. So if she doesn't deliver in that period, we can give a repeat dose of steroids. I'm not
Very
sure
good.
what dose is called, the name.
Okay, so the dose is called as rescue dose. Basically, you are rescuing the previous dose, which is why it is called as a rescue dose, and it is given if more than 7 days have elapsed. A few people say a single rescue dose should be given. A few sources say of entire course, that is your complete 2 injections of beta or 4 injections of dexa should be given. But anything is okay. Rescue dose though only should be given once. It should not be given multiple times. So a total of steroids can be given only twice and not more than that. So the rescue course can only be given once, and that also should be more than 7 days after the previous course has been given. Why not to give more than 2 doses or 2 courses of steroids? What is it going to lead to in the fetus?
It can increase the risk of cerebral palsy, sir.
Yeah, cerebral palsy. Very good. So I do not want to give cerebral palsy to the baby, hence I'm not going to be giving it. Okay. But what is the reason that I'm giving all these steroids and everything for? How is it going
So
to help the fetus?
we are helping with fetal lung maturity.
Okay. How?
So, sir, lecithin is the initial, मतलब lecithin से sphingomyelin होने के लिए.
Okay. Lesser than just sphingomyelin होने के लिए okay, but how is the steroid helping that?
So the steroid helps with the surfactant production because
How?
It releases the surfactant which is stored in type 2 pneumocytes.
Very
It
good. So it
also
activates the type 2 pneumocytes and
it also increases the lung compliance and helps in potentiating the action of the postnatal steroid that that we may give to the fetus after birth.
what we give a postnatal steroid to the fetus.
No, postnatal administration of surfactant.
Okay. So basically, it increases the compliance of the lung so that when the baby is born, it will be able to breathe in its own oxygen and it won't even take much of an effort from the lungs. So it increases the compliance, and also your steroid forms a substrate. Substrate is basically raw material for the production of surfactant inside the baby. So it not only activates the pneumocytes, but it also is one of the raw materials for the production of surfactant in the body, and hence steroids are going to help. How is magnesium sulfate helping in neuroprotection? So magnesium sulfate is a neurostabilizer. It is a neurostabilizing agent which is also doing the same thing in the mother whenever she is going to have eclampsia or she has had eclampsia. So it stabilizes the neurons, and by that action, it prevents seizures after the birth. Because if the fetus is going to, if the neonate is going to have a seizure, it is also going to have a hypoxic brain episode, and that hypoxia can lead to hypoxic ischemic encephalopathy. So it prevents these seizures and it stabilizes the neurons and makes it a little more resistant to hypoxic brain damage. Hence, magnesium sulfate is a good neuroprotectant agent for the fetus as well as for the mother. For the mother, if she is having eclampsia or is has or has already had eclampsia, but for the fetus, it is classically for this neuroprotection after birth. Okay. So tocolysis, what are the drugs that you give for tocolysis?
So, sir, there is a beta agonist,
Okay,
butaline, or
okay,
isosprene or ritodrine. Then
okay,
there is calcium channel blocker, nifedipine. Then there is oxytocin receptor antagonist, atosiban,
okay,
and also nitric oxide donors like nitroglycerin, and
okay.
prostaglandin in synthesis inhibitors like indomethacin, and even magnesium sulfate can act as a tocolytic agent.
Very good. Which is the best one?
Atosiban, sir.
Excellent, etosiban. So, and which is the worst?
Sir, I think beta mimetics because they can cause risk of
Yeah,
pulmonary
very good.
edema.
So, what are the risks that are involved with beta mimetics?
Sir, it causes increased risk of pulmonary edema associated with hypertension,
Okay, what else?
asthma.
Palpitation, अस्थमा 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 अरे अस्थमा को तो ट्रीट करने के लिए हम
अरे हाँ, सॉरी
टेरबुटलिन
सॉरी
देते हैं.
सॉरी सॉरी.
It can cause tachycardia.
टैकीकार्डिया यस पाल्पिटेशन भी पेशेंट को होंगे हाइपरटेंसिव पेशेंट को भी नहीं दे सकते हम ये हार्ट डिजीज के पेशेंट को नहीं दे सकते हम ये सो मेनी कॉन्ट्राइंडिकेशंस एंड वेरी फ्यू बेनिफिट्स प्लस इन अ पेशेंट विद डायबिटिक इट इज गोइंग टू स्टार्ट सिक्रीशन ऑफ ग्लूकागॉन
And
बीटा माइमेटिक
hypokalemia.
या hypokalemia and hyperglycemia all these complications not great okay then the best is atosiban but why don't you see atosiban being used much.
I, sir, is it because it is expensive?
Yes, it is very expensive, and secondly, it has no oral form that is available. Why? Because it's a peptide hormone. And peptides, whenever you're going to take them orally, they're going to be destroyed by your hydrochloric acid. So you do not get an oral form of it. You have to give it parenterally. And unfortunately, उसका intramuscular form भी नहीं मिलता है, सिर्फ intravenous form मिलता है, which has to be kept on and on and on until the patient is in the ward. So patient को continuously दिन रात वो drip चालू रहता है and hence that can lead to pulmonary edema plus it immobilizes the patient which I do not want. It is a bit inconvenient for the patient. Hence it is a bit of a problem कि हम नहीं ले पा रहे हैं उसको इतने ज्यादा sense में and of course the high cost but the cost is not coming down because of this immobilization on a factor but for the patients who can afford definitely a very good drug. Um, you mentioned about prostaglandin inhibitor, that is your indomethacin. What is the only indication in which indomethacin is given for tocolysis?
Sir, it is preferably used in preterm labor associated with polyhydramnios less than 32 weeks.
Okay, I'll give that to you. Any other condition? Any maternal condition?
Sir, we don't know.
So in heart disease patients, you cannot use beta mimetic because that will cause tachycardia and that is going to increase your cardiac load. You cannot use calcium channel blockers because that will lead to rebound tachycardia because of hypotension. And you cannot use atosiban because that will lead to volume overload. You cannot use magnesium sulfate because anyway it is a very weak, it is anyway a weak drug, anyway a weak tocolytic. So the only good tocolytic that you have is going to be indomethacin. So in patients with any type of heart disease, more so decompensated heart disease, indomethacin is a very good agent. But the only drawback is that indomethacin might be good for the mother, but it is not good for the fetus. It can lead to fetal early or premature closure of the ductus
That
arteriosus.
is,
Yeah, and that will lead to persistent pulmonary hypertension after birth, dyspnea dyspnea, respiratory distress after birth, and hence I cannot give it after 32 weeks. It has to be given only till 32 weeks. Okay? You were
yes, sir.
mentioning about management of polyhydramnios by indomethacin. How? You were telling me now about indomethacin
Sir,
acting as
We in less than 32 weeks gestation we give endomethacin. Between 32 to 34 weeks we give nifedipine. It decreases fetal urine production and causes oliguria. Decreases the amount of the liquor.
very
Right.
good. So it is going to reduce the amniotic fluid production by reducing or by cutting short your your renin-angiotensin cycle of the fetal kidneys, and hence it is going to reduce your urine production, which is why it is going to help in reducing your polyhydramnios. So it's a good drug for polyhydramnios. Okay, we have mentioned about tocolysis, we have mentioned about antenatal corticosteroids, magnesium sulfate. Any other drug that you give in patients with preterm labor?
So antibiotics.
Progesterone, not that much. We do not really, in none of the recommendations also suggest progesterone. Progesterone is a very futile drug, I would say.
So, do we give an antibiotic cover?
Yeah, very good. We definitely give antibiotic. Why do we give antibiotics?
For preterm labor predisposes, if the rupture has been, membranes have been ruptured, then there is an increased risk of infection ascending to the uterine, I mean the membranes. So we give an antibiotic cover. Also, if we are planning for delivery, we don't want the fetus to get infected.
Very good. So, first of all, not even in just PPRM, but in any sorts of preterm labor, the biggest cause is said to be because of some genital tract infection because of the prostaglandin part that I've just mentioned. Which is why antibiotics are given to all the patients who are having threatened preterm or preterm labor. It can even be or may not be associated with rupture of membranes. So it doesn't matter whether the membranes have ruptured. Preterm hai to dena hai antibiotics. Which is your preferred antibiotic?
Penicillin.
Penicillin is only for gram positive. Anything broad spectrum?
Sir, erythromycin.
Yes, erythromycin. Yashodhara, gentamicin is contraindicated in pregnancy. Aminoglycosides are contraindicated. Azithromycin, yes, it is given nowadays. Swagatika, correct. Azithromycin is being preferred, but still the guidelines have not yet explicitly mentioned azithromycin, though I would personally prefer to give it in my private practice. But yes, you will be given erythromycin. What is the dose of erythromycin that you give?
I'm not sure about the dose, sir.
Okay, it is 250 milligrams 4 times a day, that is 6 hourly, and it is to be given until there is onset of labor or at least for the next 10 days. RCOG का guidelines का ये line है erythromycin for 10 days or till labor ensues, whatever is later. ठीक है. So these are all the drugs that you will be giving to patients in preterm labor. Okay, any other cause or risk of preterm labor that you would want to mention apart from polyhydramnios?
Sir, she also has a large baby too,
Okay, so macrosomia is one of them. What else?
and she also has gestational diabetes mellitus, which predisposes her to infections.
Okay, infections, genital tract infections. Okay, what else? Preterm
Um,
labor.
so her cervix,
Short
cervical, incompetence.
Okay, cervical incompetence, cervical insufficiency. Very good, very important cause. Apart from that, anything else? Multiple pregnancy or any lesion that is occupying your uterus, like a large fibroid, intramural or subserosal, अगर fibroid था पहले से. So anything that is occupying the space of your uterus, which includes your preterm, which includes your multiple pregnancy as well. So these are all the risk factors for preterm labor. Okay. Could you go on to the next slide? Nothing significant over here in your case. Okay, fine. Next page. So the weight gain has been more. Okay, next. Why have you mentioned no history of exposure to radiation?
Sir, exposure to radiation in first trimester can cause fetal congenital anomalies.
Okay, and fetal congenital anomalies can lead to polyhydramnios. Okay, next. Okay, fine. So now that you have a female with polyhydramnios, what is your management for her? You at this gestation can give indomethacin. You have given indomethacin, but it has not worked. What's next?
We can do amnio reduction.
Okay, what are the indications for doing amnio reduction? There is only one indication to do amnio reduction, and that is if the female is having respiratory depression or respiratory embarrassment. If the female is having high amount of difficulty for breathing and she cannot even lie down, it leads to immediate respiratory difficulty. That is the only indication that you will be doing amnio reduction. Amnio reduction is done very gradually because if you do it rapidly, it will lead to abruptio placentae. So amnio reduction is one of them. We were talking about PPROM. What are the various tests you were mentioning it earlier for diagnosing or detecting amniotic fluid?
Sir, we can do nitrogen test, fern test, or night blue sulfate test can be done.
Okay. So what is the pH of amniotic fluid?
It's 7 to 7.5, but 7.2 is
Okay, so a little bit on the alkaline side.
alkaline.
Fine. Do you know that a lot of vaginal tract infections and even your blood, which is released during show and bleeding per vaginum in your case, can make your litmus test or your nitrogen test to be falsely positive? So it is a very low specificity indicator, alkalinity, checking for the alkalinity of of whatever is there, the secretions in the vagina. Is there any more specific way that I can diagnose and tell that this is definitely amniotic fluid?
Is there kit test which will
Yes,
detect the
there is a kit
placental
test. We call
protein?
it
Amniosurance.
AmnioSure. AmnioSure, very good. What is the content? What is the biomolecule that we check inside it?
PAMG1 protein.
Very good. What is the full form?
Placental protein. Not sure, sir.
Placental alpha macroglobulin. So PAMG, placental alpha macro, not micro, macroglobulin is what you test. The other molecule that you can also test is insulin-like growth factor binding protein 1, IGF BP1. Is one more thing that you can test for in the amniotic fluid to be able to determine whether it is amniotic fluid or not. You get those urine pregnancy kit जैसे करते हैं वैसे ही kits आते हैं जिसके अंदर you have to just put a drop and you would know whether it is your amniotic fluid or not. Now that we are anyway talking about amniotic fluid, how do you determine whether the pulmonary maturation has been achieved by the fetus? What are the various tests?
Sir, there is a lecithin sphygmomyelin ratio.
Yes, very good. What else?
Uh,
Phosphatidylglycerol level.
Yes,
for,
very good. What else?
uh,
So basically, it is all based on the fact that your surfactant, whenever it is being produced inside your lungs, is going to be spilled out through the trachea into your amniotic fluid. So all I have to do is to determine whether my amniotic fluid has adequate amounts of surfactant that is present. So there are
uh,
various ways of determining it. So various
so
ways, yes. Tell me.
surfactant albumin ratio also.
Okay. What else? There is
Syringe.
someone who mentions shake test. What is shake test?
So, sir, amniotic fluid is mixed with ethanol and then it is shaped. So, if there is a ring of foam which
Yeah, so
is
if it is
stable,
foaming, then it indicates that there is adequate amount of surfactant in it. So that is one of them. So basically, all the tests are to determine whether there is surfactant, and surfactant is mainly made up of phospholipids. So you test for various phospholipids in your amniotic fluid to determine whether they are above a certain threshold to determine whether the amount of surfactant being produced is adequate enough. That is it. Fine. So that is it about your amniotic fluid and the way you will diagnose it and how would you know what are its contents. Next slide. Okay, not significant. Next slide. In the obstetric history, do you think there is anything that you would be specifically looking for? in the previous
Sir,
babies?
there is abortion which we don't know the cause for.
Okay, very good. What might be a potential cause in your case?
Sudden IUFD.
What? Sudden IUFD and abortion. Does that even sound right? How can an abortus have IUFD?
Sir, we can look for previous preterm deliveries.
Okay, previous preterm delivery is right, but you were mentioning about the abortion. Your abortion, if there is a history of spontaneous abortion, then you might think that this may not be gestational diabetes mellitus, but instead it might be overt diabetes mellitus, and because of diabetic embryopathy, your previous pregnancy is aborted. Very likely. Also, for a female who has a BMI of 19, only 19, has had a previous baby whose weight is 3.1 kgs, which is kind of big for her. So it is very likely that even that baby had macrosomia, though it delivered vaginally, but the baby was quite big in comparison to what her body habitus is. Which is why I would like to think that maybe she might have had overt diabetes mellitus, or she has had an abortion and had a slightly baby that is heavy in comparison to her own body. And that is what it will make me into thinking that maybe I'm looking at a case of overt diabetes more so because now I also have polyhydramnios in this current pregnancy. Okay.
Yes,
Yes,
sir.
sir.
Okay. Next slide. She is currently on metformin daily, one tablet daily. Okay, what is, we'll talk about metformin in our diabetes session. Nothing significant here. Okay, next slide. Family history, not significant. Personal history, okay, nothing. Next. Okay, next. Next slide. Okay, next. Examination. Okay, so pre-pregnancy BMI, grade 1 pedal edema. Okay, fine. Nothing significant here. Next slide. Vitals, mm, okay, fine. Fine then. How do you manage this patient now? 31 weeks.
Sir, she is less than 34 weeks and she has no signs of infection or chorioamnionitis. So we would like to preserve the pregnancy up to um, as much as possible for steroid cover as well as antibiotic dosage.
Okay,
So we would like to administer tocolytics, steroids, and antibiotics, and then because her baby is large in the USG, we would like to check for estimated birth weight. If it is large or there is CPD, we would proceed with C-section.
okay. Do you think CPD can technically happen at 31 weeks? कितना भी बड़ा baby हो?
नहीं नहीं हो सकता है सर बट जस्ट टू डू
Unlikely, but it can happen in future. Correct. Okay, चलेगा. Mm, you mentioned that about PPROM. What are the various other differentials that can lead to you having watery discharge inside your vagina? Apart from your amniotic fluid, what are the other ways or other reasons in which you can have fluid in your vagina?
तो सर vaginal discharge.
It can be urine because of stress urinary incontinence.
Okay, urinary incontinence, that is very correct. What else? Urge incontinence, very common in pregnancy. What else? A female with previous vaginal delivery. What may be one of the reasons?
Vaginosis or vaginal infections or fistula.
Yeah, fistula. Everyone is answering correctly. So, a vesico-vaginal fistula that has been undiagnosed all these years, and now that she has come to your clinic after so long, is when you get to know that there is a fistula in the anterior vaginal wall. Very likely that it may happen. So, that is one of your major reasons that your patient has previous vaginal delivery, unattended tha, obstructed labor tha second stage mein. It has led to a fistula with the vagina, with the bladder. Okay. So you're going to try to pull this pregnancy and you're going to give her steroids and everything. Fine. Uh, so that is it about today's session. So I would just answer the questions that have been asked in the audience. And those questions have been asked before. Those questions are, by the way, kindly put, if there are any doubts, kindly put it in the comments and please put the feedback form. Please enter the feedback. Anish has asked, in cases of idiopathic polyhydramnios with preterm labor, how would you differentiate between true idiopathic and undiagnosed gestational diabetes mellitus or fetal anomaly? That's a very poor question, honestly, because undiagnosed gestational diabetes mellitus, I'll just do her OGTT test and check whether she has diabetes. Then I'll do her USG malformation scan करूंगा, anomaly scan करूंगा, and I will check whether there is a fetal anomaly or not. So how do you differentiate? I'll just do the specific tests. Apart from that, the next question is that what are the most sensitive Doppler parameters for predicting fetal compromise in polyhydramnios? Doppler parameters, the same Doppler parameters. The Doppler parameters are never going to change. In polyhydramnios, they are never going to change. In oligohydramnios, you may have umbilical artery, uh, what do I say, resistance might be there in these patients. Okay. So apart from that, is there, according to you, is there any correlation between AFI and likelihood of spontaneous preterm rupture of membranes? Yes, there definitely is a correlation that more your AFI, there is going to be an increased chance of PPROM. All these questions, Anish, they seem like you have made them from AI. These are very senseless questions, honestly. By the way, Chaitvvi, could you just tell me the threshold, the diagnostic threshold for polyhydramnios and oligohydramnios?
So
More
there are
than 2000
so
ml
so there on USG there is a single deep pocket and uh,
amniotic fluid index.
AFI more than 25 indicates a polyhydramnios and less than
Single dipus pocket in more than 8 centimeter indicates polyhydramnios, while less than 2 centimeter indicates oligohydramnios, and AFI less than 5 centimeters indicate.
Okay. Until which gestation do you prefer to do you prefer to do your single deep vertical pocket, and after what gestation do you do AFI?
not sure, sir.
24 weeks. Until 24 weeks, you will be looking for single deep vertical pocket, and after 24 weeks, you will be starting looking at your AFI in the four quadrants. The reason is that until 24 weeks, the baby is so small that there are no real quadrants. It is all a continuum. Whereas after that, because the baby has grown adequately in the uterus, you will start having various quadrants. Apart from that, the history, okay, nothing. Any other queries? Any other doubts? No other doubts. Okay, fine. I've put the feedback form in the comments. Kindly fill that up. Apart from that, that is it from the session today. So thank you so much. Why four injections जब दो में काम हो रहा है? Mohak has asked why four injections जब दो में काम होता है. The reason is that your pulmonary lung maturation is concentration dependent thing. So when you are giving four injections, you're ensuring that the levels of corticosteroids in your blood stay high throughout the 48 hours duration. It is a thing about half-life. The half-life of Dexa is shorter than the half-life of beta-methasone, and you somehow need to cover 48 hours, and hence you have to give four injections and not just two. It is a thing about half-life as well. So thank you so much. And that is it from today's session. Chaitvi and Darshana, it was a good presentation, but I do believe you could have performed better. You could have read a little more on it because this is a very common topic in your exams. But yeah, that was a decent presentation. So thank you so much. I've put the feedback form. Kindly fill it. And if you all have any doubts, kindly let us know on the chat, in the chat as well as in our group. We'll be discussing this. The next session is going to be on Saturday. Yeah, there is a question. Please explain the relation of dexamethasone with fetal clock. So fetal clock क्या होता है? The placenta is going to be in close contact with the adrenal gland and adrenal gland of the fetus. So in this, the adrenal gland starts producing steroids which stimulates the placenta to begin labor. It's a very closed concept. I will post a picture of it on the group and you all will be able to understand it better. I'll discuss this more on the group because I have a picture of this which is going to make the understanding much easier. There is a concept that I've discussed just a month back. So I'll explain that. Apart from that, that's it from today's session. So thank you so much, everyone, and we shall discuss the next topic on the coming Saturday at 10 p.m. So until then, thank you so much and good night.
Thank you, sir.